Welcome, good morning and good afternoon, depending on what time zone and region you're calling in from. I'm Selina Lo. I'm the Executive Director of the Australian Global Health Alliance, and I'm truly delighted to welcome you to the launch of a new report by the Australian Federation of AIDS Organisations and UNAIDS titled Actions on HIV and Health Security are Mutually Reinforcing, a call for better integration. I'll be chairing this session, which has been prepared in partnership with UNAIDS and AFAO. I begin this meeting by acknowledging the traditional custodians of the lands from which we meet. I meet you from Melbourne, Australia, on the land of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present and future. I also wish to acknowledge First Nations peoples globally, and to acknowledge each of you for giving your time in trust to us today. I thank all the speakers and the panellists who are joining us across multiple time zones and regions for giving their precious time to a topic which is a critical global health challenge. Our jam-packed agenda for today is as follows. First, we will have opening remarks putting the paper in context from UNAIDS, followed by a presentation of the paper by one of the authors. Then we will open our panel and invite all the panellists onto the screen, and we will have a discussion looking at what this paper has brought up in the context of country, global and regional health security, foreign aid and multilateral investments. I will then throw the session open to a Q&A, and we will have closing reflections from Associate Professor Helen Evans of the Nossal Institute for Global Health. This session is recorded. I ask that at any time that you start to put your questions into the Q&A box, and we will start to curate them for the panellists. If you're experiencing any technical difficulties, please contact us in the chat function or the Q&A, and we will endeavour to assist as best as we can. I call out to any students in the session, please identify yourself as such so that we can try to respond to you too. And without further ado, I wish to introduce Eamonn Murphy for opening remarks. Eamonn is the Regional Director, Asia Pacific, UNAIDS. He has also been UNAIDS Country Director in Myanmar and Vietnam. He has held a number of senior positions with the Australian Government, including Assistant Secretary for Communicable Diseases and Environmental Health and Director of the National AIDS Program for the Commonwealth Health Department. Over to you, Eamonn.
Thanks very much, Selina. And firstly, good morning, good afternoon and good evening for the different parts of the world that are logging on. I'm pleased to be here at this launch of the new occasional paper prepared by UNAIDS and AFAO. We've done a number of these collaborations, and they are very important for us to put out old thoughts, new thoughts, remind people of some of the issues that we are all collectively addressing. Today, it's about the paper Actions on HIV and Health Security and are mutually reinforcing, a call for better integration. Let me acknowledge at the outset Jim Tullett, Helen Evans, Felicity Young, Darryl O'Donnell, Rita Bhatia and others involved in the production of the paper, and the Global Health Alliance for this event today. Why would we work on this? In the wake of several prominent disease outbreaks like COVID-19 most recently, and previously Ebola and Zika, among others, global health security is once again high on the international agenda. COVID-19 has especially put global health security as a forefront issue and made the whole world yet again aware of the broader implications of a pandemic. But regrettably, health security is often only seen to be about new, acute, immediate public health issues such as COVID-19. And it excludes long-standing issues like HIV, TB or malaria that are also threats to individuals and communities and potentially to national and international health security. The responses also seem to overlook and forget many of the lessons to be learned from these prior responses or the existing responses to diseases like HIV. We see the same issues emerging, such as intellectual property, availability of treatments, preventative vaccines, when we look at COVID and how the response is around the world. Issues long dealt with by HIV, yet many responses to COVID nationally and globally seem to start over without applying these lessons learned. Yet, at the same time, in a number of countries in our own region and elsewhere, the expertise of the HIV community is being brought in to lead responses to COVID. This is what we need to see more of. but it's a mixed response. And we time and time again hear the need to start something new and fresh and forget the lessons learned and the experience of the past. So as you'll hear and see in the paper, since its emergence, HIV has been a health security issue, and it remains so today in parts of the world. But over time, it has received less attention in the health security context. 21 years ago, the UN Security Council, for the first time, discussed a public health issue, HIV. Afterwards, WHO listed HIV on the list of 10 threats to global health. But increasingly, it, like others, like TB, malaria, become forgotten pandemics in the context of public health, security, and issues for the global community. But we know, many of the people in this audience working on these issues know firsthand that it's far from over. Asia and the Pacific region has the second largest HIV epidemic after sub-Saharan Africa. 5.7 million HIV positive people are currently estimated to be living in this region. 95% of the infections are in key populations, which is one of the critical issues making it hard to respond. COVID has also seen resources redirected and services for HIV, TB and other programs stopped or interrupted, which is reigniting epidemics in parts of the region. Not all of those who need HIV treatment have it. Almost 1 million people do not have treatment, and resources to address HIV and other long-standing issues are dropping each year. The world now has a new global AIDS strategy, 2021 to 26, that clearly focuses on people left behind in the AIDS response, a critical issue for this region, and the inequalities that fuel epidemics of all sorts, including COVID. It also indicates a high cost for not meeting the agreed upon targets that countries across the world have recently adopted. For instance, 3.2 million new infections and 1.7 million new deaths are projected if the global targets are not met by all countries. So as we'll hear today, epidemics like AIDS are not over and must be included in the global health security agenda, both to learn from and not repeat the same mistakes, as well as to maintain focus on the work still to be done. We have seen the emergence of multi and extremely drug-resistant TB and malaria, as well as high levels of drug-resistant HIV in countries as close as PNG. Therefore, we propose that a new integrated approach to global health security is required, because only then will it fully work. This approach must capture not only novel acute health threats like COVID-19, but also devastating ongoing pandemics and major communicable diseases like HIV, TB, malaria. An integrated approach to global health security would also break down silos and allow learning and a collaboration across a range of diseases, more rapid responses when needed, and more efficient use of strengthened health infrastructure, personnel, and financial resources to address overlapping pandemics. Further, many vital lessons learned from HIV through decades of effort to limit its impacts to include the engagement of communities involving community leaders at the center of responses can be applied to strengthen global health security. Health security approaches must also ensure that they do not contribute to the fragmentation of health systems, which hamper effectiveness and efficiency. The approach must be collaborative, cohesive, and embedded in universal health coverage, UHC, and other existing health programs that have much to offer to strengthen health security. Integrated approach must also embrace a broader notion of health security that secures the engagement and support of the most vulnerable communities and countries. We are only as safe as our weakest link. Countries with the weakest health systems and most vulnerable to diseases will only buy into a new approach to global health security if it addresses the threats that matter most to them. Global health security cannot be based on individual countries acting solely in their national interests. The path to greater global health security must ensure that external support to the countries most affected by disease threats is timely, adequate, and recognizes that the countries themselves know best their context and their own communities, must be in a spirit of global health solidarity and our shared humanity. Failure to adopt such an integrative, holistic, cohesive approach, especially in the aftermath and the ongoing impact of COVID-19, would be a huge missed opportunity. So it's timely to document these compelling approaches and other ethical approaches in a paper that we are launching jointly with the Global Health Alliance and AFAO here today. The paper, funded by UNAIDS and developed with AFAO in the lead, is a critical next step in sharing the lessons learned from HIV for other public health issues. Lastly, but not least, let me also thank and commend the Government of Australia for its ongoing leadership to secure health security in this region and globally. Since 2017, the Australian Government has also committed funding to the Indo-Pacific Health Security Initiative to address infectious disease threats with the potential to cause social, economic harms on national, regional and global scales. I'm sure we'll hear more from Sarah Goulding during the panel today on the newly announced plans by the government to build on this initiative. I thank you all for your time, your interest, the questions that you put to the panel, and to the panelists themselves for their contributions today. And this is the beginning of a conversation on how we can strengthen public health security for the Indo-Pacific. Thanks very much. Back to you, Selina. Thanks.
Thanks so much, Eamonn. I now have the delight to welcome onto the screen Adjunct Professor Darryl O'Donnell, who is the Chief Executive Officer of the Australian Federation of AIDS Organisations, which lead Australia's national community-led effort to end HIV and support stronger civil society responses to HIV in the Asia and Pacific. He has more than 25 years' experience in HIV community research and public sector roles, and is also an adjunct professor at the University of New South Wales. Delighted to hand over to you, Darryl.
Thank you so much, Selina, and thank you everyone for joining, and to Eamonn for the remarks. I think they set a really nice foundation for the discussion today, for the panel discussion that we'll have. Before we turn to that, really what I want to do is just take a little bit of a deeper step into the paper and to set out some of the key propositions, perhaps some of the key provocations that the paper puts forward as a discussion point. As Eamonn remarked, this is the second occasional paper that we've co-published jointly with UNAIDS, and the third that AFAO has produced. And really what we're hoping to do with these is to be thoughtful about some of the challenges that we face here in our region, in Asia and the Pacific, but also globally in taking forward the effort to end HIV transmission. Tonight, health security. And some of the questions that we're exploring in this paper are, what are we talking about when we're talking about global health security? Is HIV a health security issue? And how does HIV and other major communicable diseases, TB, malaria, hepatitis C, hepatitis B, how do they fit into a dialogue on health security that's so dominated by acute health emergencies? The timing is prescient. We've got COVID-19, the havoc it's wreaking all around us, and everyone today is talking about curves and modelling and vaccines and testing like never before. Everyone today is an expert, everyone has lived experience, and everyone actually has a stake in the choice points we face and the public health decisions that leaders are taking. And it seems that in that environment, it's a very ripe environment for us to be thinking about a new dialogue on health security, both as it's been and as it should be into the future. To the next slide, please. So what are we talking about when we're talking about global health security? Like all such concepts, this is endlessly contested and it'll evolve over time, but the WHO has given us a reasonably good working definition here. In their imagining, health security is really about bringing imperatives to action, a focus on minimizing vulnerability for populations, but a very clear recognition of the cross-border nature of health security threats. And while HIV and other major communicable diseases are often captured within definitions and frameworks for health security, the general perception is that health security relates more to novel and acute threats, things such as SARS and MERS, and of course, to COVID-19, rather than established and ongoing major communicable diseases such as HIV, TB, malaria, and viral hepatitis. And so we see this distinction between emergent and established diseases in global and often in national public health systems and architecture, we see distinct and siloed financing, strategy setting, coordinating arrangements for HIV and for other major communicable diseases, and those operating quite distinctly and independently of systems for health security. This separation and the siloing actually contributes to the fragmentation of health systems, and that hampers their effectiveness and efficiency. So our starting proposition here is that through a more collaborative and integrated approach, HIV has much to offer health security, and health security also has much to offer HIV. To the next slide, please. So the first major point from the paper that I'd like to share tonight is that in an environment of fragmented approaches to diseases, a heightened focus on emerging diseases risks coming at the expense of established diseases. And if that occurs, both lose out. So HIV and major communicable diseases would lose out because attention turns away from them before we've actually reached an acceptable level of global control. This results in disease resurgence, squandering the gains that have already been made through decades of investment and effort. But likewise, health security also misses out because the expertise, the networks, the infrastructure that support the programs addressing long-standing endemic communicable diseases such as HIV, those things deteriorate and become unable to support the rapid mobilization and response that's needed for health emergencies. To the next slide, please. So let's explore a little bit more what HIV might offer for health security. And Eamonn's really opened this up beautifully. Foremost, it offers learning. We've been at this for 40 years now, and we've actually come to understand quite a few things along the way. We've become very expert in effective responses to HIV. And I want to be careful here because overgeneralizing the lessons of one pandemic to that of another, whether we're talking about COVID or any other disease, is of course a great danger. But there's also a great error in not taking up the lessons that apply when we thoughtfully consider them. So what do we know about HIV? Well, one of the defining characteristics of HIV is that it's a lifelong infection without a vaccine and without a cure. And so for prevention and treatment, we depend entirely on the voluntary cooperation of those most affected, and we depend on it for life. So in HIV, we're very, very conscious that the choices of individuals and people and communities matter a great deal to public health outcomes. And we know that investing in communities to support the continued adoption of healthy behaviours is an essential investment. So from HIV, a critical lesson is that people and what they do shape disease outcomes. We also know from HIV that governments are limited and constrained, especially in matters of the private sphere. We know human rights and public health are not matters to be balanced and traded off, but actually that the protection of human rights is essential to public health gain. And critically, we know from HIV that public health efforts must target the most vulnerable and those who will be left behind. That is, in effect, that we must put the last mile first. But it's more than learning that HIV offers global health security. The work of the Global Fund and others to ensure adequate supplies of essential HIV commodities at affordable prices has been leveraged powerfully during COVID. Critical interventions such as the WHO-led Access to COVID-19 Tools Accelerator, which is speeding up the development of and access to diagnostics and treatments and vaccines, those things are built upon years of investment and experience in securing HIV and TB and malaria commodities through pooled procurement and strengthening the supply chains for their distribution. Similarly, HIV programs that are so dependent on robust epidemiological data have invested heavily in digital platforms and surveillance capability. And laboratory capacity, political leadership and community community systems are other examples of foundations from which health security benefits and that can be leveraged for greater gains. But before moving on, let's consider a different question. If the lessons, systems and skills of those mobilised on HIV can contribute to health security outcomes and can be further leveraged in that direction, what can greater attention to health security offer in return? What does it offer for HIV advocates? And to answer, I'd suggest that we actually re-examine the lessons and systems and skills that we have on this slide. Imagine if HIV advocates were backed in by a global health security community that was working to strengthen political leadership for public health. Or if the health security community as a whole was focused on laws and regulations and policies, such as the criminalisation of drug users or undocumented migrants, that actually hold back HIV efforts and force people underground and away from health services. Or if community strengthening were not a slightly strange preoccupation of HIV advocates, but actually a widely backed, widely supported and serious program of public health gain. To the next slide, please. So the second important point I'd like to highlight from the paper is that the investments in HIV and other major communicable diseases have actually provided critical learning, systems and personnel that underpin responses to new threats. But likewise, there's a simple truth. We won't get to the end of HIV without there being stronger systems for health that a global health security agenda can offer. So HIV offers much to health security, but it also has much to gain from the enlarged alliances of people working together in common cause. To the next slide, please. So finally, to the third point I'd like to make, to the elusive question of integration, and really to the question, are we serious? Integration across diseases is not new. HIV and TB, HIV and STIs are obvious examples. But what of a broader program to bring HIV and major communicable diseases into the health security arena, and in doing so, to transform both? There's some ambivalence about this integration of programs, and we should expect that. There are, after all, really appreciable risks. Does integration fragment already inadequate funding? Does it divert the attention and efforts of already overstretched policymakers, of health and community workers? Does it actually generate inefficiency and ineffectiveness when some things are integrated that are better done with singularity of purpose? Does it lead to a loss of hard-won visibility and recognition? And for those who are already left behind, not least key populations most affected by HIV, these are not abstract questions, but practical matters of access to prevention tools, tests, and to life-saving treatment. So while the risks are appreciable, we shouldn't mistake that for them being insurmountable. And of course, the discussion of risks need to be balanced by consideration of the gains too. So in this paper, we suggest that a sensible approach would be for major diseases programs, for HIV and for others working in those areas, to be working now with other elements of the health system, and especially those being developed with a health security focus, to discuss which components of their program are most amenable to integration and when. Soon, in the midterm, or not at all. And this not at all category might include components that really do need high-level expertise in single disease teams. This approach recognises that the different components of the health system should have less to do with the biological nature of diseases and more to do with the nature of the program responses they require. Health issues that are predominantly addressed through diagnosis and treatment may be more easily integrated into general health services. Those that require intensive community-based work, for example, on preventive measures or case finding, motivating people to seek treatment, might be integrated to take advantage of common expertise and infrastructure. But an integrated approach to health security would break down silos, and it would allow learning and collaboration across a range of diseases, more rapid responses when needed, and more efficient use of infrastructure, personnel and financial resources. And it would also help ensure that long-standing and still devastating epidemics are not pushed aside by a focus on new threats and acute crises. There is a compelling case for an integrated approach to HIV and global health security, as the pragmatically and ethically right approach, and with HIV and major communicable diseases at the core of global health security. A failure on our part to ask the questions about the degree to which better integration can generate wins for major communicable diseases, but also wins for health security, is morally wrong in the context of resource scarcity. And in the wake of COVID-19, with the attention of the world fixed on health security, it would be a huge missed opportunity. To the final slide, please. Just to echo Eamonn, I just really particularly want to acknowledge Jim Tulloch, who's the lead author for this paper and who actually joins us tonight from Europe, but also other authors who are joining tonight, and particularly for AFAO's part to acknowledge and thank UNAIDS for their funding support, but also for their partnership, for their intellectual leadership in bringing together this paper, and to the Global Health Alliance for hosting us tonight. Thank you so much.
Thank you very much, Darryl. That was a wonderful presentation, and thanks to all the authors for your efforts on such a seminal paper. So I'd like to welcome all of the panelists onto the screen, and as they come up, I'm going to introduce them, and then we will start off our panelist discussion, and hopefully, if we can keep to some time and gain a bit more time, we'll be able to open up for a little bit of Q&A before we reach our closing remarks. So as they come up onto the screen, we first have Tina Boonto, who's and if you could wave actually, Tina, so that the audience can know who's who if the names don't come up. Tina is currently the UNAIDS Country Director for Indonesia. She's over 2 decades of experience in health and development. More recently, she coordinated the development of the new Global AIDS Strategy, Ending Inequalities, Ending AIDS 2021 to 2026. We also have Professor Brandon Crabb, the Director and CEO of the Burnet Institute. He's the long-term Director and CEO of the Burnet Institute. He's also Chair of the Australian Global Health Alliance and Pacific Friends of Global Health. He's a Fellow of the Australian Academy of Science and the Australian Academy of Health and Medical Science, and is the former President of the Australian Association of Medical Research Institutes. And for the last 6 years, he served on the Governing Council of the National Health and Medical Research Council of Australia. We have Sarah Goulding, really delighted to have you, Sarah, Assistant Secretary, Department of Foreign Affairs and Trade, and is also the Board Vice Chair of Gavi, the Vaccine Alliance. Sarah is responsible for Australians' investments in global health funds. Previously, she was the Senior Specialist Gender Equality of DFAT and has also overseen Asia-Pacific programs in a broad range of sectors, including health, education, private sector development, and economic reform. She served in Suva as the head of Australia's aid program to Fiji and Tuvalu. And finally, truly a big welcome to Dianne Stewart, head of donor relations at the Global Fund to Fight AIDS, TB and Malaria. Dianne's calling in from Geneva, so very early for her. She has a long history with the fund and is currently has also worked previously at the Global Financing Facility for Women's and Children's Health at the World Bank, the GFF. She served as Director of the Information and External Relations Division at UNFPA and was Vice President at IAVI after working extensively in the past with UNHCR. So I'd like to open the panel, and Tina, if you don't mind, I'd like to start with you. Tina's going to give us a more country perspective in terms of the gaps in experience on the ground, and I'd be interested to ask you what you have seen as some of the big challenges in delivering HIV/AIDS interventions recently. What has worked well, and what do you think is the future of an integrated approach from your perspective? Over to you, Tina.
Yes, thanks, Selina. I'll just get right to it. We have so little time and a lot to say. As you know, of the estimated 500,000 people living with HIV in Indonesia, only 66% know their status, 26% are on ARVs, and 6% are known to be virally suppressed. And COVID in 2020 has disrupted the HIV response even further. In mid-2020, there was a drop in HIV testing by 60% and ARV initiation by 40%. So numerous challenges and disparities remain, starting with the topic of HIV and the key populations that are disproportionately impacted by HIV. They're also the people who are marginalized, economically insecure, and not supported by social protection schemes. So for many people living with HIV in key populations, seeking healthcare for themselves becomes secondary to their basic survival and well-being of their family. And we have heard reports from COVID surveys that people living with HIV in key populations experience income loss, 70% of them, and they were unable also to access social assistance to cover this gap in this time. And during lockdown, there were increased cases of violence against women living with HIV. And also many people from the HIV community reported anxiety, depression, suicidal tendency, and had needed really a lot of support on mental health. The second challenge that we're always facing are poor services. These poor services overall make people deprioritize or delay seeking health care. If you have to show up at the clinic and wait 5 hours or more, you would be afraid to miss your work and then perhaps be fired. Stigma and discrimination makes children hide taking their ARVs or stop taking them because they don't want to be known that they're HIV positive and then subsequently be expelled from school. And many other obstacles remain, and I think these are the heart of the challenge, is that people are being persecuted for their sexual identity, their choice of work, drug use. Women are denied access to safe abortion. Young people are blocked from accessing information and health services via the age of consent laws. And these difficult issues will need to be addressed before we can actually move on and have some semblance of health security. But there are opportunities, and I think COVID has shown us the first opportunity that we can tap into large community networks to complement the public sector. CSOs, we know, are able to rapidly mobilize their communities. They monitor the needs, they deliver ARVs, they provide social and livelihood support. So we see an opportunity of providing social contracting that will enable communities and civil society organizations to access domestic financing, particularly funding that will allow the communities and non-government sectors to tackle social determinants of health and not just focusing on service delivery. Secondly, we see in Indonesia, 82% of Indonesians are already enrolled in national health insurance scheme. That's huge for a country of 270 million population. We have also these district level standard minimum service package that already include HIV, TB, and malaria. So this is a guarantee across the 514 districts. So there is opportunity to expand one-stop services and integrated health approach that would go beyond the silo of HIV and include RH, STI, hepatitis, TB, mental health, harm reduction, etc. And thirdly, we have 200 million internet users in the country, and Indonesia is advanced in terms of development and use of online application. We've seen COVID movement restrictions force the development of telemedicine, usage of telemedicine, online apps that simplifies ARV deliveries, specimen transport. This has really been rapidly and historic groundbreaking time in terms of getting through the red tape and the long notorious approval procedures that the country is known for. And we also have this ambition to produce locally medical commodities, including vaccines, and this would be great. It would benefit the entire health system, including the HIV response, as we are also still grappling with weak uncoordinated procurement supply management, which impacts then on our program and service delivery. So, I mean, to conclude, I mean, I think there are so much to learn from this crisis, and we are needing to press upon the government and the country to really seize this opportunity to build back better, increase investment in prevention, in the health system preparedness, and ensure everyone, regardless of economic status, sexual orientation, whether or not they use drugs, everyone enjoys equal, equitable access to health and quality health care. And we must confront these difficult issues, and only then we can say we have health security for all. I hand back to you, Selina. Thank you.
Thank you so much, Tina, for those insights. Critically important, and It actually is a fantastic segue into my next question, which is for Brendan. Brendan, I'd like to ask you, we're currently, as Tina so eloquently outlined, at a critical juncture really in the modern history of global health. Global health is not that old, but the modern history of global health. How can we take ourselves out of all that we've not addressed well in health, even pre-pandemic, into the opportunities the pandemic has offered? What are these opportunities? And also, if you have time, what are the risks?
Yeah, thanks, Selina, and thanks, Darryl and Eamonn and Tina, who set the scene really well. Well, we're in, it's an understatement to say a disruptive time. This is the biggest disruption since World War II. We really will, there'll be a time pre-COVID and time post-COVID that's totally different. I don't think most of us can even remember our time pre-COVID because so much has happened. And so the context for me is that presents enormous opportunities and enormous risks for health security, as I understand it, and so been so beautifully introduced in a number of different ways. As always, I think Darryl touched on it. Fascinating the different ways we describe it. But for me, health security is securing the health of those who are in a fragile circumstance for whatever reason. They might be in our own community, they might be, and of course often they're in low and middle income countries. And through securing the health of those people, reap the benefits that we sometimes more selfishly understand as health security, securing our national security, securing our economy, securing the health of a rich Western nation, all of those things that are the vexed issues that the loaded issues with that term health security. But securing the health of those whose circumstances are fragile, and there's enormous opportunities for why we might be able to do that better. The first of them in this cataclysmic COVID thing that's happened, I think, is, Darryl mentioned before, everyone's an expert. I mean, I don't know, I've never seen a measurement of the awareness of the sorts of issues that are relevant to us, what a virus is, what a vaccine is, what an epidemiologist is. We've got about, 4 billion of them in the world now who would consider themselves epidemiologists. We really do imagine that. I've been in sort of science promotion in one way, shape or form, my 30 years of working life. And we're lucky if the whole science in Australia gets a clip in the paper or in the 7:30 news, maybe just before the sport, once a week. I mean, seriously, that's when science gets talked about, a virus, and it's a human interest story. Now, of course, it's the lead story in every news media every day, as it's been for 500 or 600 days straight, and will be for probably the next 300. It's phenomenal. So if you have to measure that awareness, this is an incredible opportunity in the health security space, at least in terms of infectious diseases, isn't it? And I think the second realization, which is less obvious than that, and perhaps less dramatic for the moment, but it's the recognition of the interconnectedness of the world. Pandemics, by their very definition, are global. And I'm paraphrasing Peter Sands, and Dianne, it might even been of you who sent this around, but Peter talked about the pandemics of the past being sort of shoved aside, shoved to the corners of the world where they were less visible. Malaria that I work mostly on used to be in 210 countries in the world, is now in about 90 countries in the world. And the 100 that it's not in now are quite wealthy, and they've forgotten, they don't think malaria is a problem anymore. And of course, tuberculosis and to a large degree, HIV can tell the same story. Actually, most diarrheal diseases, most pneumonia, causes of pneumonia in the same category, and so on. So, but it is actually much harder to do that with a respiratory infection like COVID. And more and more in the next year or so, we're going to recognise that as we continue to confront viruses that come into developed countries, or just trying to do business. You know, even with malaria, if you go to a highly malarious area, it's hard to do business. It will be very hard to do business with a high COVID area, even if you're vaccinated. We're learning the difficulties of that. So the interconnectedness of the world is something not quite as in your face as this awareness point, but I think we can make quite a lot of that. And the third and final opportunity is what I call the anything's possible. You know, COVID, a vaccine in a year. I've worked on vaccines for 35 years, and I put a fast pace at 10 years. I put a phenomenally fast pace at 10 years to go from conception to licensure. Happened in a year. This is unbelievable. As just an example, the amount of money it takes to deal with a health issue, and how you need to spend that. You know, in Australia, there's been an awful lot spent on keeping people in employment, keeping people, keeping businesses going, and so on. The idea that you can spend tens of billions and hundreds of billions on a problem that is worth trillions is now not an abstract concept. It's very real now. Anything is actually possible. It's the story. There's no constraint by, gosh, an extra billion for the Global Fund or Gavi's a lot of money. That is not a constraint anymore. In conceptually, obviously, it's still hard to actually make happen, but it's a much easier conversation to have than before. So I think that the risks have also been touched on, and it's why I'm so in favour of integration. I think the big risk is it's too hard. It's too hard. We're exhausted. What do you mean another disease? This is now a shopping list of things that we've got. We have to avoid the shopping list, and at the same time, take advantage of the COVID obsession. It is a COVID obsession. So how can we take advantage of that for HIV, TB, malaria, and other core, health security, global health issues? I actually don't think we have much of a choice. We run a really high risk to not at least ride the coattails of COVID, which we're going to have to deal with for 2 to 5 years realistically. And I think we may as well set our minds to that. Yes, globally speaking now. And and the other risk perhaps is that we don't fully appreciate right now, those high-level, game-changing opportunities that I mentioned. This is because we're sort of a frog in slowly increasing temperature water. It doesn't hit us in the face as it perhaps should, that it's a fundamentally different world. The way we used to do things is gone. It's not business as usual anymore. And so, thanks. Darryl really made my key points for me. And I'm very, very keen for us to look at ways to be integrated and to think of a scale that is different to what we used to think of. Thanks.
Thank you so much, Brendan. It actually goes directly to, so we've had now the challenges, we had some of the opportunities outlined clearly. I'd like to ask Sarah because everybody looks at aid assistance and increased funding as the solution, one of the solutions. How has the pandemic changed aid assistance in the region for DFAT? And if you could also answer, in global health, it's about all of us, not some of us. How does the department view the role of Australian aid in the world beyond our region? Thanks so much.
Thank you so much. And I'd just like to begin by acknowledging the country of the traditional elders whom I'm talking to you from, the Ngunnawal people, and acknowledge their elders past, present and emerging, and any Aboriginal and Torres Strait Islander people who have joined us today. Look, you have invited the department to be part of a really powerful and important and timely conversation. This is a really impressive and important piece of work that you have done and shared with us. There's three things I'd like to reflect on in talking to you about this today. And I guess the first of them is really the understanding that that there is within the government in Australia, in the Department of Foreign Affairs and Trade and the areas that I work in global health, but in others, about what this pandemic has meant. And when we, from the moment that it was first talked about, you know, we were tracking it in the Centre for Health Security and other places, and really seriously concerned about what it might mean for the countries that we are so committed to work with in Southeast Asia and the Pacific. And, you know, when we look at where we are now, it is such a challenging place. And I think, Brendan, your comments just then about it's a different world. It really is a different world. We do have some countries that have, like in Indonesia, you were reflecting, Tina, who have experienced real devastation with the virus. Then we have some other countries like Tonga that have never had a single case. But have experienced a really profound economic and social and trade isolation as their border becomes their biggest protector. So we've seen a real divergence in experience, but absolutely what we have seen is we have seen an impact in every country in the region, and that impact being profound. And that's in terms of the pandemic itself, but also in terms of HIV, in terms of tuberculosis, looking at routine immunisation, but even sexual and reproductive health, you know, the experience of sexual and gender-based violence, stepping out of health, looking at children out of school, joining you from school holidays in lockdown in Canberra. It's increased poverty rates. I mean, there are a lot of different multi-dimensional impacts in global health that practitioners and who work in global health really understand, and they have absolutely come to the fore. So the first thing I wanted to say is, you know, your question around how has the pandemic changed the aid assistance, it's absolutely made everybody really understand how critical health is to the social and economic and stability fabric of all of the countries in our neighbourhood. The second thing that I'd like to say is that in every space that there can be, and this was documented, shared in a Partnership for Recovery statement that the Foreign Minister released last year, we have changed what we're doing and how. So it doesn't matter what program you're working on, nothing that is supported by the Australian Aid Program hasn't had to refocus and how it works in order to respond to the impact of the pandemic and support people. But in particular, it has really highlighted health, and the work of my colleagues in the Centre for Health Security has been front and centre of this. There has been a really significant increase to our work support for Gavi through the COVAX Advanced Market Commitment, $130 million. There has been a very significant contribution to a Access to Vaccines initiative for the Pacific and Southeast Asia. And so there has been a real increase. But I guess the third thing that I wanted to say in terms of how Australia has responded is that we have really focused on how we can make those announcements have a very fast, have a very tangible impact in the countries as we engage with them, because the timeframes that countries have is acute, whether you've had many cases or very few. The level of fear in communities is very high, and the impact is required now. So one thing I'm very proud of is the work that Australia has done to share some excess doses from our own AstraZeneca, manufactured here in Melbourne. Over 3 million doses have gone out now, all across the Pacific and in countries in Southeast Asia, including just, I think, 2 weeks ago to Vietnam and Indonesia. So we are really trying to work along every front. But one of the things that I think is most powerful is this question around access to COVID-19 vaccines, and the conversation around health does really focus in some places, in large part, around supply and delivery. It doesn't always focus on the space that it should, which is around access. Who gets access to those doses? And for me, I think one of the biggest lessons that I saw, the biggest learnings that you highlighted in this really important paper, was how critical it was to look at who needs to be reached, who's unlikely to be reached. Where does that inequality sit in order to get a really effective COVID-19 vaccine campaign, to have a really effective pandemic response? And if I look at the conversations that have happened internationally through COVAX, through the Gavi board, that I've seen my colleagues have through all of the work in the Global Fund, and the huge resources that's been able to mobilise into supporting key populations, continued work on HIV, TB and malaria, as well as the pandemic response. And then what we've been able to do with UNAIDS and other partners, it has been really having a laser eye focus on shifting the conversation from access to, at the macro country level, to access to the critical populations in a community who are most likely to be excluded. And I think that's a really powerful lesson. The last point I thought I might reflect on, which is again one that you highlight in your paper, is the one about the importance of partnerships. And you've asked me to reflect on this, Selina. Clearly, if we're going to be candid, every institution does sometimes find itself in a little bit of a competition with another. And I think one of the most extraordinary achievements and strengths of the response to the pandemic that we have seen from within government and in Australia with many of you here, but also globally and in the region, is the commitment to actually collaborate, to step out of any sense of turf and to just say, you have this strength. You have this strength. We know that the communities that need our support most need us both. Let's work out how we can do it together. And I think that whether you're looking at the global level of the ACT Accelerator, or you're looking at the collaboration that AFAO is doing with UNAIDS in the region, or that Burnet Institute is doing in East Timor, you know, you're seeing some really powerful points of connection and collaboration. And for that, I would like to commend all of you and thank you. Over to you, Selina.
Thank you so much, Sarah. I'm really grateful that you can be here with us today. So for those of you who are worried about time, we've had some agreement that we'll go over a little bit because I recognise that we will also have a couple of questions that we'd like to fit in. But Dianne, I'm sorry to come to you last, but what can we as a global health community learn from countries leading in global health investment? And where do you see all this fitting in regards to the next Global Fund strategic framework? Just a few of your insights would be welcome.
Thanks, Selina, and thank you very much for the opportunity today. The advantage of coming last is that everybody's already made some excellent and very intelligent points. So there's not much left for me to say. Perhaps what I can do is illustrate some of the key things, the themes that I think people have raised and give a reflection from the Global Fund's perspective. Firstly, on some of the issues around how we can ensure that the lessons from HIV are learned for both COVID and for future pandemics. and also the concern expressed by many that maybe, you know, we would forget about the infectious diseases we haven't solved yet and focus on, you know, future theoretical pathogens as we move forward. I think the Global Fund has illustrated really well how you can bridge all of these different conflicting pieces, and to the points raised about how do we make sure that we don't leave certain groups behind, and certainly leave low and middle income countries behind. I think that's exactly what we've tried to do over the last year. You will have seen from our results report that we sent out about 2 weeks ago that the good news is that we've, in the last 20 years, saved 44 million lives. And therefore, we've shown that we know what to do to beat back infectious diseases in whatever form they come. And that's fantastic. But what was devastating about the report was the impact that COVID had, particularly on HIV, and I'll focus just on HIV today because that's kind of our subject, which is that we saw a massive impact on the HIV programming, particularly on prevention services. So an 11% decrease in people being reached by prevention services, a 22% decrease in people being actually tested for HIV, and where entry onto ART increased slightly. I mean, there's now 29.9 million people on antiretroviral therapy. Many of the other prevention services, including medical male circumcision and other things like that, dropped drastically. And we saw similar impacts in TB, with the most dramatic impact being on extremely drug-resistant TB, where testing and treatment for extremely drug-resistant TB fell by 37%. That's basically a death sentence. So we're very concerned about the way in which both the COVID-19 pandemic, but also the potential impact of future pandemics could derail health systems. So what are the ways in which we were able to make a difference? Indeed, we've deployed over sort of $3.7 billion over the last 18 months in addition to fight COVID-19. That means that actually in 2020, we deployed more than 4.2 billion. That's the most we've ever dispersed in a year. So there's been a lot of investment in the poorer countries. And what that means in concrete terms is, for example, Indonesia was mentioned. We've invested an additional $65.8 million in Indonesia just over the last couple of months, mostly for oxygen, PPE, the kind of directly COVID-19 related investments, but also to change our HIV services, right? So to do more mobile voluntary counseling, to do more community-based testing. And this is where I think we can see ways in which HIV, to Darryl's point, has benefited, because we've learned how to do more community-based programming, but also where we can see how integration of these services can serve both to ensure that we reach everyone we need to reach right now and that no one is left behind, but also for future global health security, we can build systems into the community. So what Nigeria did, Nigeria is one of only 2 countries where HIV testing didn't fall, it increased massively. And that's because they integrated HIV and TB testing into their COVID-19 testing programs. So they built it on an HIV infrastructure, and all of the clinics and the community workers and so on who are used to doing HIV testing did COVID testing as well, and offered TB testing and HIV testing to people who came for COVID tests. And they created a shift mechanism in the laboratory. They ran HIV tests during the day, they ran COVID tests overnight. And this is where you can see how some of the sort of health infrastructure and the integration of infectious diseases across a health system, people-centered health system, can actually respond pretty well to big shocks and big health shocks. Moving, because I know we're really out of time, so moving very briefly to our new strategy, I think many of the key points have already been made in terms of how we need to orient our strategy going forward. One is to focus on community outreach and making sure we're leaving no one behind. And our new strategy has as intersecting objectives both the building of health systems and capacity, so an integration objective, that is paired with a human rights-based, equity-based, leave no one behind objective. So it's both a systemic one and a targeted prevention that will go to key populations, to the most vulnerable in society. And it speaks a little to the question in the chat around sort of decolonizing global health security. I think the lens that we took from the beginning of the creation of the Global Fund, but then we doubled down on it during the COVID pandemic, is a lens of equity. If health interventions are available in high-income countries, they need to be available in the poorest countries. And that speaks to the principles we need to use going forward. We need to build our pandemic preparedness on the basis of the services that are being used and provided on a daily basis. That will create a strong sort of security network, if you want to use that word, that will ensure health for everybody. So I'd love to talk more about that, but just with the last point I'll make on the equity lens is just to remind everybody that the COVID-19 pandemic is not over. And a focus on only vaccines is actually impeding the response to us getting through this pandemic. We need to have an integrated response that saves lives now and that provides oxygen and protects health workers and all those things as we roll out the vaccines. And so our plea is that the $7.7 billion, that is a huge gap across the COVID response right now, is one of the biggest priorities we need to do before we start talking about future architecture for pandemic response. Thanks very much.
Thank you indeed, Dianne. So we are really pushed, but the conversation has been fantastic. We've been voting for the questions, and most of the audience can see the open questions. We're going to find a way to answer your questions. Don't know the result yet, but we will put it on our websites and also perhaps we'll curate some answers to the questions that we haven't been able to answer because the Q&A is cut so short. But the top question, and I'd like someone to answer this in literally 60 seconds, is has COVID-19 brought a greater understanding among the broader community and governments of the role of the social determinants and social support in health security? And how do we keep this on the agenda in better times? Does anyone want to take a stab at that in less than 60 seconds before I hand over to Helen? Darryl, maybe?
Definitely Darryl.
Less than 60 seconds. It's a challenge. I'm so sorry.
Look, really, really big question. I think it's actually taken us forward in some ways, and yet I think for a lot of us that, certainly a lot of us who've been around global health for a long time, or a lot of us have been around HIV for a long time, we sort of watched the COVID pandemic response and despair at the lack of learning from things that we have lived through, but we are still living through. So some of those things about social determinants, which should be so obvious here in Australia, where we're rushing to get to 70 and 80%, and we're forgetting that it's not just about getting to 70%, it's about getting the right people to 70%. It's about not getting the first 70% of the most privileged with the greatest access. That's not the time to be opening up. It's time to open up when we've actually looked after those people who are vulnerable, those people who we know will be left behind because they don't have access to health systems in the way that those of us who live with privilege do. So yes and no. Yes, we are learning about vulnerability, and no, we forget and forget and forget again. I know that's a non-answer.
No, it's an excellent answer. Thanks so much for rising to that challenge on the spot. So thank you so much to all the panelists. And it is with great delight I invite Associate Professor Helen Evans from the Nossal Institute for Global Health just to give some closing remarks. Helen was Deputy CEO at Gavi in Geneva and previously Deputy Exec Director at the Global Fund. She serves on the boards of so many amazing foundations here, Fred Hollow's Foundation, the Burnet Institute, and also on our advisory board of the Australian Global Health Alliance. She's an amazing asset to the global health community in this region. So over to you, Helen, for the final remarks.
Thank you, Selina. And as Dianne said, one of the advantages of being the last person is that actually everything that I would have said or was planning to say has really been said, and I know we're out of time. I just wanted to reflect a little bit that we are exactly a year, Darryl, I think, since we started on the AFAO International Advisory Group talking about this paper, this occasional paper, and it was stimulated by the implications of the COVID pandemic for HIV services and support, which a number of the panel speakers today have pointed out has had a really very strong and negative impact. But it was also stimulated as much by the lessons we've learned from HIV that we can draw on to handle the new pandemic. So I'm just going to make 2 points. First of all, relates to HIV and the HIV community. Darryl's actually covered this beautifully, but I do want to stress that handling new challenges absolutely doesn't mean abandoning or moving on from HIV. A more integrated approach to handling ongoing pandemics and emerging threats can really be a benefit all round. So, I think it shouldn't be a threat. It should be seen as a very positive step forward. The paper covers, I would really commend the paper to you because it covers a lot of the really incredibly important points that we've learned from HIV, and our very strong response that's been a result of multilateral intersectoral collaboration. And as Sarah said, collaboration is absolutely key. Engaging communities as equal partners, not a token gesture, etc. I think I would also support Darryl's point that regrettably, we're not very good, once again, at learning from previous experience. So there are lessons that we could have learned from HIV that we haven't, but we need to look forward. And I think there's a big message about, which is in the paper, about thinking long-term and staying the course. I mean, I think it's inevitable and to be expected that the first priority of a responsible government in a pandemic will be the well-being of its own people. However, this is also about being good regional neighbours for Australia and good global citizens. It's about not responding to populist pressure and just closing down and looking inwards. And we saw some early good practice in collaboration. I think the ACT Accelerator was a very exciting initiative on global solidarity and commitment. Unfortunately, that has sort of waned a bit. So I think there's a message there for us. I'm going to bring to my second point I wanted to make, and that's relation to the term health security. And I noticed in the chat there were some comments on that, because it does come with some negative, if unintended, connotations. And I just want to be very clear that the ultimate goal of is about improving health for all. It's not about protecting high-income countries against public health threats coming from lower or lower middle-income countries, nor is it about militarising responses to public health. I think we need to be absolutely clear about that. If we need new terminology, maybe, I sort of think health security is now well embedded, but we just need to make sure there's a clear understanding that the health security agenda has to be underpinned by respect for human rights and values, collaboration, equity, and it should aim to build resilience and sustainable long-term systems approach. It's not a short-term fragmented crisis approach. So I'm going to stop there, and concluding comment is to thank all the people involved, but most particularly Jim Tulloch, who really did the heavy lifting on this. Jim did, all the drafting, and a number of us commented and etc. But big thanks to Jim, and to AFAO, of course, for initiating this, UNAIDS for collaborating. And once again, thank you to the panel. I think there was a really rich discussion. So thanks very much, everybody.
Thank you, Helen. Thank you, audience, for your patience. Thank you, panelists, and particularly UNAIDS and AFAO. When a conversation like this ends and you feel like it needs to keep going, it means it's usually the beginning of a longer conversation. So if you have that inkling or feeling, try to engage with any of the panelists or authors on the screen today and with the global health community at large. And we welcome you to a conversation next time. So thanks for joining, and good night from Melbourne.